Hi guys, so Jason Matthew here, and today we're going to be looking at Neuroscience 5. We're going to be looking at Parkinson's disease, which is an example of a neurodegenerative disorder. Now, what do these people have in common? And I guess common sense should prevail. We are doing a lecture on Parkinson's disease, so it means that all these people here, unfortunately, they suffer from Parkinson's disease. Well, let's go on. Now, as I said before at the start, Parkinson's disease is a neurodegenerative illness, and you're supposed to be able to define what a neurodegenerative illness is. So let's look at this. Neurodegenerative illnesses are characterized by the progressive loss of selected neurons in discrete brain areas, resulting in characteristic disorders of movement, cognition, or both. Alright, so some key things here. For a neurodegenerative illness is progressive, and it's specific types of neurons you're losing, and it's taking place in specific areas of the brain. And it will manifest itself in disorders of movement, cognition, or sometimes, unfortunately, both of them. Alright? And today we're going to be looking at Parkinson's disease. So, at the end of this lecture, you should be able to tell me that it's the specific type of neurons that are being affected, which part of the brain is being affected, and is it a disorder of movement, cognition, or both. So Parkinson's and Alzheimer's diseases are two neurodegenerative disorders that respond to drug therapy. Parkinson's disease is associated with a loss of dopaminergic neurons in the substantia nigra. So you have already started to answer some of the questions I was asking before. We now know that for Parkinson's disease, it's a loss of a specific type of neuron, the dopaminergic neuron, and it's taking place in a specific part of the brain, the substantia nigra. So it means that later on when we're looking at drugs, they should be ideally targeting these dopaminergic neurons in the substantia nigra. So a little background here. Now, Parkinson's disease, it got its name Parkinson from the person who first discovered it, or first described it, which is James Parkinson, and he described it as shaking palsy in 1817. And he produced this paper here called Shaking Palsy. And just to give you a little quote from it, he says, "Involuntary tremulous motion with lessened muscular power in parts not in action, and even when supported, with a propensity to bend the trunk forwards and to pass from a walking to a running pace, the senses and intellects being uninjured." So he was describing Parkinson's disease there. Alright, so as I said, Parkinson's disease is a progressive neurological disorder of muscle movement. It is characterized by tremors, muscular rigidity, and bradykinesia, which simply means the slowness in initiating and carrying out voluntary movements. You also have postural and gait abnormalities. Most cases involve people over the age of 65, among whom the incidence is about 1 in 100 individuals. So as you get older, you have a higher chance of developing Parkinson's disease. Now let's remember, Parkinson's disease is a progressive disorder. It's going to get worse as you get older. And you see here they have categorized Parkinson's disease into 5 stages, 1, 2, 3, 4, 5, with stage 1 having minimal or no functional impairment until you reach stage 5, where the patient is restricted to the bed. Alright? So some classic symptoms of late-stage Parkinson's disease includes a stooped and rigid posture, like if you look in there on the diagram, shuffling gait, tremor, and mask-like facial appearance, Alright, so you're seeing that there in the diagram. And anyone who has seen recently Michael J. Fox and Muhammad Ali on TV, you'll see those characteristic symptoms. Now, as the disease proceeds towards its last stage, you see here the trunk is almost permanently bowed. So let's see some other things about Parkinson's disease. First of all, the cause for most patients is unknown. We just don't know how you got it. The disease is correlated with destruction of dopaminergic neurons in the substantia nigra. Please remember that if you write any essay about Parkinson's disease, this is something that you must put in. Right? And because there's a destruction of the dopaminergic neurons in the substantia nigra, there's a consequent reduction of dopamine actions in the corpus striatum parts of the brain's basal ganglia system that are involved in motor control. So what you should be already putting down as you're taking your notes along the way is that people who suffer from Parkinson's disease is because they have low levels of dopamine in the substantia nigra. So I hope you have made that link already. Alright? So low levels of dopamine in the substantia nigra will result in Parkinson's disease. So it means that as we go later on, it means what? If we're looking at a treatment for Parkinson's disease, exactly, you want to increase the levels of dopamine in the substantia nigra. And there are different ways or mechanisms in which we could employ to do that. Now, Parkinson's disease, unlike schizophrenia and so on, it doesn't have a genetic factors. There are no genetic factors that play a dominant role in Parkinson's disease. Alright, so it doesn't mean that if there's Parkinson's disease in your family, it doesn't necessarily mean that you will be susceptible to the disease. Alright. Environmental factors may play a role in the loss of dopaminergic neurons. There are some studies that show if you live close to those large farms where they do these spraying of pesticides and so on, they see people who live around those areas have a higher incidence of Parkinson's disease. But often the case is idiopathic, alright, and it may follow a stroke, virus infection, and can be sometimes even drug induced, alright. So as I said, there are shown studies where, like, you have spraying of paraquat and some other things that that people who live around those areas, they tend to have a higher incidence of Parkinson's disease. Right. So this is just a diagram to show you that in Parkinson's disease there is less dopamine being produced and there's loss of dopaminergic neurons. So you see here, the loss of dopamine neurons in the substantia nigra is evidenced by diminished overall uptake of dopamine precursors in this region, which can be visualized using positron emission tomography and the dopamine analog fluorodopa. So you see here you have different, you have a key here. Now when it's yellow, orange kind of color, it means that there's high fluorodopa, and you see that that's present in the normal individual. But when you look at the individual with the Parkinson's disease, he's not taking up much of this fluorodopa, showing that there's a lot of there's less dopaminergic neurons in that area, so there's loss. All right, and that's characteristic of Parkinson's disease. Now here's another thing. For proper motor control, for proper muscle function, there must be a balance between two neurotransmitters. There must be a balance between dopamine and acetylcholine. So here is a healthy individual who will have normal muscle function, normal motor control, and that's because there's a balance of acetylcholine and dopamine. Now here's the thing. If in Parkinson's disease your dopamine levels is getting less, it means that this balance here between dopamine and acetylcholine is now no longer there. So there's an imbalance. Alright, and that also leads to loss of motor control, loss of muscle function. So one way in which you could treat Parkinson's disease is to regain this balance. So if your dopamine drops low, it means that if you decrease the amount of acetylcholine to give you back that balance, you might see some alleviation of these Parkinson-like symptoms. All right. So it's always important to have a balance between dopamine and acetylcholine for proper muscle function, motor control. So there is a list here of a lot of anti-Parkinson drugs, and we're just going to spend some time on a few of them. All right. The go-to drug is L-Dopa or Levodopa, and you see that Levodopa works best when he's working with friends like Carbidopa and Amantadine and so on. And we also have Selegiline that we'll talk about later on. So drugs used in Parkinson's disease. And it is important that you know from now that there is no cure for Parkinson's disease. Maybe somebody who is listening to this podcast right now will be the one to find a cure in the future, but currently there are no cure. All we can do presently is the drugs that we have presently is to offer temporary relief from the symptoms of the disorder. All right, but it cannot stop or reverse the neuronal degeneration caused by disease. So unfortunately, you're going to get worse if you have Parkinson's disease. The only thing that we can do presently is slow down that process, all right, and make your life as comfortable as possible. All right, but as I said, I'm sure somebody who's reading this podcast right now, in a few years' time, might find a cure. If you do, big me up, please. I'll like it. All right, now this is unfortunately for us to know about Parkinson's disease, we need to do animal experiments. All right, and it's a sad thing, but some might argue it's a necessary thing because it helps a lot of humans along the way. All right, now these are using the rhesus monkey. All right, and there's a drug called MPTP, and basically what MPTP does is that it destroys dopamine neurons in the substantia nigra. So this monkey, when you give him the MPTP, he's going to have Parkinson-like symptoms. And basically what they were showing here is that when you give the animal L-Dopa, it was able to reverse the process. So that's how we knew that L-Dopa was a good treatment for Parkinson's disease. So drug treatment of Parkinson's disease. Drugs that replace dopamine, all right, example, Levodopa. And it's normally, as I said, it normally comes with friends like Carbidopa. And we'll see the relationship there just now. Also, drugs that mimic the action of dopamine, such as bromocriptine and percolide and so on. All right. Now, before I even go further, remember, let's recap. Someone who is suffering from Parkinson's disease, they have low levels of dopamine in the substantia nigra. So we're going to find different ways to increase the amount of dopamine in that area of the brain. All right, and two ways here is to use either Levodopa, which is a precursor. So when it goes into the brain, you're going to make more dopamine, or you could use an agonist, which will mimic the action of dopamine. So it will also bind to receptor, and it will also give you the desired effect. And we'll see some other things. We could have a MAO-B inhibitor like Selegiline. We could have drugs that promote the release of dopamine from the remaining dopaminergic neurons. And there with artane, this one here. Remember what I showed you all just now with the balance between acetylcholine and dopamine? So instead of interfering with dopamine, what you're doing here is that you are doing an acetylcholine antagonist, which will lower the levels of acetylcholine. So you can regain that balance. So that's the next thing you can look at. Alright, so before we go on any further, let's talk a little bit about the synthesis of dopamine. Now, dopamine, norepinephrine, and epinephrine, they are what we call monoamines. Because if you look at all three of them, they have just one amino group. Now, and all three of them are related, and all three of them came from this amino acid, tyrosine. That's a popular exam question. So please note that dopamine, norepinephrine, and epinephrine, all three of them came from this amino acid, tyrosine. Alright, now for Parkinson's disease, we are particularly interested in this reaction here. which is L-Dopa, alright, going to dopamine. So remember what I said, that dopamine, norepinephrine, and epinephrine are what we call monoamines. Alright? Now there's another name for them, and that's because if you look at dopamine, norepinephrine, and epinephrine, they all have another common group, which is the catechol group. Alright, so if you watch all three of them, you'll see that all three of them have a catechol group. Alright, so let's write that too. Catechol. C-A-T-E-C-H-O-L, I believe. Alright, check it out. Alright, so catechol, and that's with the benzene ring and two hydroxyl groups. So all three of them have them. So they have a catechol group, and they also have one amino group. So dopamine, norepinephrine, and epinephrine are also called catecholamines. Alright? So they're also called catecholamines. Now let's go back to this reaction here. This is the one that we are particularly interested in terms of talking about Parkinson's disease and how the drugs will be acting. So the precursor for dopamine is L-Dopa. And if you look at the structure of L-Dopa and compare it to the structure of dopamine, the only difference between the two molecules is this guy here, this carboxyl group. So when you lose remember in biological reaction, when you lose the carboxyl group, you lose it as carbon dioxide. So you lose one molecule of carbon dioxide. So the L-Dopa is converted to dopamine. And when you're losing carbon in the form of carbon dioxide, that's what we call a decarboxylation reaction. Hence, the enzyme that catalyzes this reaction is called aromatic amino acid decarboxylase, because this is a decarboxylation reaction. So I hope you understand that. So this will be important for Parkinson's disease. Right, so the sites of action of Parkinson's disease drugs. And there's some little things here. Please know our key, L-Dopa, Levodopa. 3-OMD, the OMD stands for O-methyl-dopa. DA will stand for dopamine. AADC will be the enzyme that we just looked at, which is aromatic acid decarboxylase. DOPAC will stand for dihydroxyphenylacetic acid. And MT will stand for methoxytyramine. Alright, so that is just a key that we're going to be seeing happening just now. But before I go on, I should also say that this slide is very cool, but I cannot take credit for it. I got it from the internet. Unfortunately, I did not write down the site I got it from, so I can't reference it. So if anybody knows the reference for this, please send it to me so I can big up this guy who took his time and did this. This is not my slide. I got it from the internet. Now, let's look at this. So this is the neuron here. This is a dopaminergic neuron. So you have the presynaptic cell, you have the postsynaptic cell, and the postsynaptic cell will have dopamine receptors. So you want the dopamine to basically bind to these receptors. Alright. This side here is the substantia nigra. This is the brain. This is the outside of the brain. Now remember, you have to cross a blood-brain barrier. Alright. And a point to note is that you might think that, well, hey, if this patient, this person is suffering from Parkinson's disease, has low levels of dopamine, why don't we just give the patient dopamine directly? The thing here is this: the blood-brain barrier. Dopamine, as well as most other neurotransmitters, they cannot pass the blood-brain barrier, so we can't give them it directly. All right. So let's see. Now, on the periphery, in other words, in the rest of the system, which is the human body, L-Dopa, alright, which is a drug that we commonly use for the treatment of Parkinson's disease. And the reason why we're using L-Dopa is because L-Dopa could pass the blood-brain barrier, but dopamine cannot. Alright, so L-Dopa could cross and could form dopamine. And I want you all to keep in mind that there's low levels of dopamine in the substantia nigra in a patient suffering from Parkinson's disease. So you are trying all kind of different ways to increase either the concentration of dopamine, or you're going to increase the release of dopamine from the presynaptic cell, or you're going to decrease the reuptake of dopamine from the synaptic cleft, and you're going to decrease the breakdown of dopamine in the synaptic cleft. So all these different things are ways, strategies in increasing the amount of dopamine that is binding to these receptors here. So you're going to get the effects. All right. Now here's the problem. When you give a patient L-Dopa, the L-Dopa can be decarboxylated to dopamine on the periphery, and that now the thing is that there is not only dopamine receptors in the brain, there are dopamine receptors throughout the body. So if the L-Dopa is decarboxylated to dopamine outside of the brain, you could have a series of side effects that we'll discuss in a little while. All right. So L-Dopa can be decarboxylated to dopamine on the outside in the periphery. Now, one drug that can prevent that is Carbidopa. So Carbidopa is a dopa decarboxylase inhibitor. In other words, it will inhibit this reaction in the periphery. So L-Dopa will not be converted to dopamine because Carbidopa will inhibit that reaction. Alright, now Carbidopa cannot cross the blood-brain barrier, so it just remains in the periphery. Now you might think, well, alright, good. So the L-Dopa is not breaking down in the periphery. More L-Dopa will reach and cross the blood-brain barrier. That's a good thing. But here's what's going to happen now. Because you're blocking the dopamine decarboxylase, or I should say the dopa decarboxylase, because you're blocking that, alright, another reaction could happen now where you could have catechol O methyltransferase enzymes converting the L-Dopa to 3-O-methyl-dopa. Alright, so the L-Dopa could be converted to 3-O-methyl-dopa by catechol O methyltransferase enzymes. Alright, that are also present in the periphery. And this reaction is only happening because Carbidopa is preventing the conversion of L-Dopa to dopamine. Alright? And so normally a patient who's getting L-Dopa is also given Carbidopa to block this reaction, and he's also given a COMT inhibitor to block the conversion of L-Dopa to 3-O-methyl-dopa. Because here's the problem with 3-O-methyl-dopa. 3-O-methyl-dopa, it competes with L-Dopa to cross the blood-brain barrier. So you're getting less and less, well, first of all, some of the L-Dopa is being converted to 3-O-methyl-dopa, so there's less dopamine reaching the brain. And now the 3-O-methyl-dopa and the L-Dopa will compete to cross the blood-brain barrier. So you're getting the drugs to reach slower to the brain as well. So it's less and slower. So bad both ways. So most of the times when you're giving a patient L-Dopa, you also give them a COMT inhibitor as well as a Carbidopa. And in fact, some drugs even combine like that. So you just take it in one shot and it has all three components: COMT inhibitor, L-Dopa, and Carbidopa. Right, so by using the COMT inhibitor and the Carbidopa, we have ensured that the maximum amount of L-Dopa reaches into the brain. Now, L-Dopa is pharmacologically inactive, meaning that it wouldn't give you the pharmacological response. The L-Dopa has to be decarboxylated dopamine by the aromatic acid decarboxylase. When the dopamine is then released from the presynaptic cell, it will bind to its dopamine receptors. Alright? Now eventually, there's going to have uptake of dopamine from here back into the presynaptic cell. There are drugs that could prevent this uptake. Also, there are what we call dopamine agonists. They resemble dopamine so that they bind to the receptor, and they also give that effect that dopamine would have. Now, when dopamine is in the brain, is released in the synaptic cleft, there are other things that could happen to dopamine. The dopamine can be broken down by what is called MAO. Now, MAO are monoamine oxidases. And what they do, they break down monoamines. I remember I just told you that dopamine is a monoamine. So what we try to do now is to increase the life or the length of time dopamine will remain in the synaptic cleft. So it gives it more time for dopamine to bind to receptors. So we try to prevent the breakdown of dopamine in the brain. So we use a COMT inhibitor, but in this case it can be carbidopa, because carbidopa cannot cross the blood-brain barrier. But there's another drug called tolcapone that could cross the blood-brain barrier and inhibit COMT in the brain. So that can be used. Another cool thing going on here is that MAO, so the monoamine oxidases, they have different isozymes. You have MAO-A, you have MAO-B. Now MAO-A is present in the brain, but it's also present in the liver and the gut. Alright? MAO-B is more prevalent in the brain only. So if you could get an MAO-B inhibitor, that would be ideal, because MAO-B inhibitor, MAO-Bs are more present in the brain. So if you can inhibit that, that would be a good thing. So you prevent the breakdown of dopamine. Now why I'm saying MAO-B inhibitors are good is because they are more prevalent in the brain. If you get an MAO-A inhibitor, you're going to get side effects, because it's going to be inhibiting MAOs, monoamine oxidases, not only in the brain, which is dopamine. It's going to also inhibit monoamine oxidases in the liver and in the gut, and that can lead to some serious side effects. In fact, I'll give you a little homework. Go and read up what happens when tyramine builds up in the gut, and see what and tell me what happens there. It's bad stuff. Alright, so let's recap some of the stuff that we just learned. The mechanism for L-Dopa or Levodopa. Because dopamine does not cross the blood-brain barrier, Levodopa, the precursor of dopamine, is given instead. Levodopa is formed from L-tyrosine, which we saw already, it's an amino acid, and is an intermediate in the synthesis of catecholamines. And I already told you all what the catechol group is, what the amino group is. Levodopa itself has minimal pharmacologic activity. So it means that we have to decarboxylate the levodopa. Once it gets into the brain, once it crosses the blood-brain barrier, it has to be decarboxylated so that it can form dopamine. Levodopa is rapidly decarboxylated in the gastrointestinal tract. Prior to the advent of decarboxylate inhibitors such as Carbidopa, you would have needed to use a large oral dose of levodopa. Alright? So let me just make sure you all understand point 4, because point 4 is very important. What we're saying, alright, is that ideally you want the L-Dopa to reach the brain, and when it crosses the blood-brain barrier, the L-Dopa will be decarboxylated to dopamine using a decarboxylase enzyme. Now what we are saying is that that will be the ideal situation. Unfortunately, these decarboxylase enzymes are not only present in the brain, they are present throughout the body, especially like in the gastrointestinal tract and so on. And you are given levodopa orally, so you see what's going on happen here. It means that before levodopa reaches the brain, some of it would have been decarboxylated to dopamine, and the rest of your body also has dopamine receptors, so it leads to side effects. And the problem here is that if you do not use a decarboxylase inhibitor such as Carbidopa, it means that if you want a certain concentration of levodopa to reach the brain, you would have to use a higher concentration of levodopa to compensate for some of it being broken down systematically before it reached the brain. Alright, so we had a problem of toxicity from dopamine. Alright, this was before we started to use Carbidopa. Alright, now here's the next thing about levodopa. Alright, tolerance to both beneficial and adverse effects occurs with time. And here's the important thing, levodopa is most effective in the first 2 to 5 years of treatment. Alright, so once you put your patient on levodopa, you have that honeymoon window, let me say, of 2 to 5 years where it's going to work, and it's going to work really good. But then after that 5 years of therapy, patients have dose-related dyskinesia and inadequate response or toxicity. So after the 5 years, that honeymoon period, the L-Dopa starts to give trouble. Alright, now if you watch throughout the lecture, I'm using terms like dyskinesia and so on, right? If you all don't know the meaning of it right now, fine. Go and check it online. Go and check a medical dictionary. When I was doing my stuff, Stedman was my go-to dictionary. So check it out. Right? So Stedman's medical dictionary was my book back in the day. Right, so this is what happens. Levodopa has some serious adverse effects. The principal adverse effects include anorexia, nausea, and vomiting. That is with initial administration. Alright? But it could also have cardiovascular effects, including tachycardia, arrhythmias, and orthostatic hypotension. And you could also have, if you start using levodopa, you could have mental disturbances, including vivid dreams, delusions, and hallucinations. And I'm not going to give it away just yet, but we're going to be doing schizophrenia next. And schizophrenics are people who produce large amounts of dopamine in the brain, and they suffer from delusions and hallucinations. So can you see the link that if you're giving somebody levodopa, that they could have symptoms that are like what a schizophrenic will have, who suffer from high levels of dopamine? I hope you can see it. They also suffer from hyperkinesia and on-off phenomena. Alright, so that adverse effects of levodopa was greatly observed when you administer levodopa alone to the patient. But then with the advent of Carbidopa was able to help us out. Carbidopa is an inhibitor of dopa decarboxylase. Alright, so it's unable to penetrate the blood-brain barrier. So its action is on the periphery. Alright, before levodopa reaches the brain, the carbidopa protects the levodopa. Alright, it protects it from being decarboxylated to dopamine outside. Because the only time you want levodopa to be converted to dopamine is when levodopa reaches the brain. Alright, it goes in, it crosses, when L-Dopa crosses the blood-brain barrier. That's the only time you want the L-Dopa to be converted to dopamine. You don't want the L-Dopa to be converted to dopamine before, because then it's going to lead to all the adverse effects that we just talked about. And what Carbidopa does is that it protects the L-Dopa until it reaches the brain. So as a result, when Carbidopa and levodopa are given together in combination, a few things can happen. It can decrease the dosage of levodopa because less of it is being broken down, so most of it, if not all of it, is reaching the brain. It can reduce toxic side effects because you're not using a high dose, you're using a lower dose. And there's a shorter latency period that precedes the occurrence of beneficial effects. Another drug is Selegiline. And all I didn't say the name Selegiline, we already spoke about an MAO-B inhibitor. So Selegiline, a selective inhibitor of MAO-B, which predominates in dopamine-containing regions of the central nervous system and lacks unwanted peripheral effects of non-selective MAO inhibitors. Because you see, non-selective MAO inhibitors will inhibit both MAO-A, which is mostly found in the gut and the liver, as well as MAO-B. But with Selegiline, it is only inhibiting MAO-B, which is found mostly in the brain. Alright? And that's where you want the effect to take place. Alright? You want to prevent the breakdown of dopamine in the brain, which is a monoamine. But that doesn't mean that you want to stop the breakdown of all monoamines in the body. Just in the brain where dopamine is. Not in the rest of the body. Because as I tell you, if you allow like a monoamine like tyramine to build up, that is bad. So read up about what happens if tyramine builds up. So Selegiline, which is a MAO-B inhibitor, it enhances and prolongs the anti-Parkinsonism effect of levodopa. It may reduce mild on-off or wearing off phenomena. Long-term trials of Selegiline show that the combination of Selegiline and levodopa was more effective than levodopa alone in relieving symptoms and prolonging life. So, as with any drug treatment, if you're studying pharmacology and so on, you realize that we use a combination of drugs. It's the most effective way to treat anything. Alright, so we have Amantadine now. And interestingly enough, Amantadine is an antiviral agent. That's what we initially used it for. We use it for the treatment of the prophylactic treatment of influenza. But it was found to also improve Parkinson symptoms by stimulating the release of dopamine from dopaminergic nerve terminals in the substantia nigra and delaying its reuptake. So Amantadine does two things in the substantia nigra. The dopaminergic neurons that is left there, alright, that are good, it stimulates them to release more dopamine. And what it does again, it also prevents or delays the reuptake of dopamine. So what you have is that you have more dopamine coming into that synaptic cleft, and it's going to stay there a longer time. So it's going to have enough time to bind to the receptors and stay there. So that's good. Amantadine may be more efficacious in Parkinson's disease than the anticholinergic atropine derivatives, but is less effective than L-Dopa. As I said, L-Dopa is the go-to drug. L-Dopa has shown the highest efficacy in terms of the treatment of Parkinson's disease. Alright, amantadine has been used alone to treat early Parkinson's disease. So like for instance, if you're diagnosed with stage 1 Parkinson's disease, it might be a wise idea to just treat them with amantadine. And why is that? Simply because, remember, you don't want to start off. When a patient comes in Parkinson's disease, the first thing you should do is figure out what stage of Parkinson's disease they have. Because you don't want to start off with L-Dopa. And why is that? Because when you start with L-Dopa, you know as a physician you only have about 5 years to treat this patient until things start to go bad. So you want to delay the use of L-Dopa. L-Dopa is like if you play all fours, alright. I don't know how much you all understand that game, but that is your trump card. That is your S. Alright? That is your ace. In other words, you want to play that card only when things start to get a little desperate. Alright? So that is your trump card. Once you play that, you have no more cards in your fold here that could help, that could bail you out. Alright? So amantadine might be a good drug to use if the person is diagnosed with an early stage of Parkinson's disease. And then as he progresses, then you could use L-Dopa and amantadine in combination. So the last one now, anticholinergic agents, artane. Alright, and remember, as I said from the beginning, to have proper motor and muscle control, you have to have that balance between acetylcholine and dopamine. Now, in a patient that has Parkinson's disease, his dopamine is going down. So you need to find a way to bring down the acetylcholine so that you could have better motor control and so on. So let's read. Since the deficiency of dopamine in the striatum augments the excitatory cholinergic system in the striatum, the blockage of this system by anticholinergic agents such as artane helps to alleviate the motor dysfunction. Improvement in the Parkinson tremor is more pronounced than improvement in bradykinesia and rigidity. So it's not totally foolproof. I mean, you're still going to have some problems. Although not as effective as L-Dopa or bromocriptine, it may have an additive therapeutic effect at any stage of disease when taken in combination with L-Dopa and bromocriptine. So what we're saying is that, it can make things better. It has an additive therapeutic effect, so add it into the mix. Alright, some adverse effects. Mental confusion and hallucinations. It can occur as can peripheral atropine-like toxicity. So you get cycloplegia, urinary retention, constipation, and so on. Alright, now this slide here shows the pros and cons of available drugs, and some of them, well, all of them I think we have discussed already. So you could, if you know someone who has Parkinson's disease, then this might be of interest to you. You could pause and take some notes here. So what's in the future? Obviously, we are constantly developing new medications, also new surgical targets, because we know which part of the brain it happens. Gene therapy, stem cells. I have some students doing some research on that right now, so as a library research project, not as an actual wet lab, but more of a research library research thing. Alright. Also, all that we are doing so far right now is that we know disease is there. We know that there's lots of dopaminergic neurons, and we are now trying to work with what is left. But what about if we go beyond that? We take it from a more preventative stage, a more prophylactic stage, where we say that we protect against any neural injury or degeneration in the first place. Alright? So instead of waiting for there to be dopaminergic loss, why can't we find a way to protect these neurons from the day one? Alright, so there's some interesting stuff going on. And eventually, we hope that one day, as with any other disease, let's find a cure for this. So maybe it might be you. Alright? You might be listening to this and you might be, wait, neuroscience is cool and all these diseases are cool. I'm going to find a cure for these things. When you do, please call Biochem GM name. Alright? So, just a little side note there. Right, so the next class, we're going to be looking at schizophrenia. Now in this class, we look at what happens when dopamine levels are low. We will see in schizophrenia, it's the opposite happening. Dopamine levels are high. So that's going to be a really interesting class, because if you know anything about schizophrenia, you know that is a very interesting topic. So you're going to have some fun with that. Alright, so I will see you all in the next class. And as usual, guys, if you like what you heard, please show your love, hit the like button, as well as subscribe to the channel so you're going to get all the new videos as soon as they come out. You're going to get them straight to your YouTube channel. You don't need a YouTube account to subscribe. Just subscribe, show us your love, you know. And as I always say, give us feedback. I would love to hear how my videos are helping you move forward. So put it up on YouTube, but you could also use this Gmail account to send me any questions you may have, as well as any notes or any diagrams, because I'm always looking for some really cool diagrams, some nice concept maps for students to better grasp the ideas. So these were just some graph figures I have. If you have any cool ones, please, informative ones, please send them to me so I can share them with the students as well. And as usual, guys, thank you for listening to the video. I really hope it's making a difference. And we'll talk soon. Schizophrenia is next, people. So see you then. Take care.